Thank you so much, everyone, for coming to this exciting talk. I'm really excited about this for a number of reasons, as I'll briefly mention. My name is Farhan Majid. I'm an economist who's interested in working on global health at the Center for Health and Biosciences at the Baker Institute. This is just to tell very briefly about Dr. Bhutta. There's a lot which can be said, and I don't have the time to really give him the full explanation and list of all his achievements, but just very briefly, Dr. Zulfiqar Bhutta is the inaugural Robert Harding Chair in Global Child Health at the Hospital for Sick Children, Sick Kids, the founding director of the Center of Excellence in Women and Child Health at the Arakan University, which are very unique joint appointments. One is in Toronto, and another one is in Pakistan. And he holds numerous adjunct professorships at places like Johns Hopkins, as well as the London School of Hygiene and Tropical Medicine. He's been a member of the independent expert review group appointed by the United Nations Secretary General for monitoring progress in maternal and child health. He's served as a member of the Global Advisory Committee for Health Research for the World Health Organization. He's the current president-elect of the International Pediatric Association and is a leading voice for health professionals supporting integrated maternal, newborn, and child health globally. One of the unique things about Dr. Bhutta is I think it's not just the research, but the capacity building. He's really, in Pakistan, he's been like the leading figure in terms of setting up from scratch an entire large research facility starting in 1985, and now you have 90% of, for example, community-based research on maternal and child health is done by his group or people he's been influential in setting up similar initiatives in Africa and in other parts of the world as well. He's among the many awards he's received is the Tamgha-e-Imtiyaz, which is a Medal of Excellence awarded by the President of Pakistan, as well as the Gold Medal for contributions to child health in Pakistan. Internationally, he was awarded the American Academy of Pediatrics Sam Forman Award for lifetime contributions to nutrition research. The list can go on, but help me in welcoming Dr. Bhutta. Thank you.
Thank you, Farhan, for that generous introduction. I had difficulty recognizing who you were talking about. So I'm very grateful for the invitation to be amongst you today. What I was asked to do was a very challenging thing, is to basically talk to you about public sector policies and specifically community programs in maternal and child health, something that my group has worked on for the last 20 years or so in difficult circumstances, and to principally do a comparison of those programs in relevance to other initiatives, including private sector initiatives, research projects that are at a very limited scale. So to set the scene, what I want to do is to start off with one of my favorite quotations from someone from my region, a poet and a literary giant of his time, who over a century ago made the following observation. So Rabindranath Tagore said that fate had allowed humanity such a pitifully meager coverlet that in pulling it over one part of the world, another had to be left bare. What he was reacting to was one of the great Bengal famines of his time, when he saw in front of him tremendous inequities and injustice. And his reaction to that was that this was a fate that was bestowed on many people. He changed his mind towards the latter end of his life. But what he was pointing out in terms of inequities in nutrition at that time, or in access to services, is nowhere more evident in the global context than in the situation of women and children worldwide. And you can see that quite clearly in the following map that we drew about 15 years ago when we produced one of the first global estimates of child mortality worldwide. Each one of these dots represents a cluster of 10,000 deaths. And when we looked at where these 10 million deaths were clustered worldwide, they were overwhelmingly in geographies that represented sub-Saharan Africa. South Asia, that you see over here, looks like a blur because of population density. And it tells you that the issue isn't universal. It's not even universal within low and middle income countries. And there are clusterings of these mortality that we certainly were aware of at the time when the Millennium Development Goals were set. And these goals, which are now over, and we have had enough time to reflect upon them and see what worked and what didn't work, were set broadly to look at the relationship of economics development to some health outcomes. And the two outcomes that were selected at the time in the year 2000 when the world signed up to them were those that related to maternal and child health. So the target that the world set itself was to reduce child mortality by 2/3 and to reduce maternal mortality by 3/4. And by all accounts, we did reasonably well. So if you look at certainly child mortality, from base figures of around 12 million or so deaths in the year 1990, these are estimated deaths because the first quantification was what I just showed you for the year 2000. So by the time the Millennium Goals finished in September 2015, we had brought child mortality down to about 5.9 million. And if you were to take into account population growth over this time period, then arguably the world achieved Millennium Development Goal 4 of setting itself what was an impossible target of reducing child mortality globally by 2/3. So we can pat ourselves on our back and say, well done, great global achievement. But if you look behind these statistics or figures, you begin to see some of the global challenge that we have in producing averages. Economists recognize this quite readily. Health folks typically don't. So no one said this better than Tony Lake, who within a couple of weeks of his taking over as the director of UNICEF made this observation. And what Tony Lake said was that when we disaggregate these global success figures, we find behind them not just statistical national successes, but moral and practical failures by people who've been left behind on the basis of race, ethnicity, gender, and just because they are indigenous. Now, what did he mean by this? So I think you have just one graphic to make the case. So if you look at countries that have reduced child mortality in the last several decades, you find these countries which have reduced child mortality, and then you see on the y-axis, have they done it by reducing inequality or have done it at the cost of increasing inequality? Now, what you see here in this quadrant is this whole bunch of countries, and I will not name them, where the mortality reduction was achieved largely by shifting the curve and principally having an impact on mortality reduction amongst the relatively well-off. People who were in cities, people who had ready access to care. So you were able to reduce mortality quite significantly in that subgroup, but the poor remained where they are. And as a result, therefore, you do not see necessarily in many countries a reduction in mortality with a reduction in inequity, except for a few examples. And that's one of the major reasons why, as we move forward and reevaluate where the world had gone in the last 20 years, there were a number of blind spots in the Millennium Development Goals. And I'm just going to highlight a few just to make the point. The first blind spot was that at the time when these goals and targets were coined, and I was on a committee that actually set up some of those targets, we did not have the evidence base for making recommendations and indicators, leave alone setting targets. So it was just plucked out of thin air. For example, we did not have a good sense of where were the risks of mortality, maximum. So if you take maternal deaths, most of maternal deaths cluster around the time of birth, last trimester. You take things like stillbirths and you take things like newborn deaths, they all cluster around the time of birth. So at that time, this recognition that there was something unique about these first few days of life And hence, in our global actions, we ought to focus on that Tarot time period. That realization was not there because the evidence base was neither collated nor made available to policymakers, and leave alone to the few nerds who assembled in New York to set these global targets. Now, if you look at the significance of this time period, you recognize that the first day of life, just the period of being born, and the first 24 hours after birth are where a disproportionate number of obstetric deaths, by some account, almost 70% of all maternal deaths, nearly a half of all stillbirths that I'll speak about in a second, and about 30 to 40% of all newborn deaths are clustered. So if you did not have an indicator around this first day of life, and you don't ask governments to focus their attention on that period, you do not have a metric that you can then track and trace. And 20 years on, we all look back and say, oh, we wish that we had done this. So this was one major fault in the Millennium Goals, that it did not highlight the whole issue of newborn deaths. It missed completely the issue of stillbirths. So around 3 million stillbirths, with rates in many countries exceeding 30 per thousand total births. What do I mean by stillbirths? So stillbirths are babies who are born dead. And they represent two types of conditions. They represent babies who are born dead because they died at some stage during pregnancy, in the latter stage of pregnancy. And then there is a very important subgroup which are labeled intrapartum stillbirths, so those babies who died during the process of childbirth. Now, this subgroup that you see here in dark green represents a baby who would have lived had there been good care during the process of childbirth. So by all definitions and accounts, these are an extension of newborn deaths. Yet they don't get counted, and until very recently, they were not even included in the global burden of disease estimates because there was no disability attached to it. And it took a dogfight, it took a threat of boycott to get stillbirths included in the Sustainable Development Goal indicators just a year ago. So the world has not as yet adopted this whole evidence-based programming around what we measure, how we measure, and how we include that in our national programs. So you will be surprised to note that in low and middle income countries, less than half of low and middle income countries actually measure stillbirths. So most of the information available is from modeling and extrapolation. So we made progress in reducing child mortality in the last 2 decades, but the corresponding progress in terms of reducing newborn deaths, that is the subject of my talk today, was much slower. So you don't have to be a statistician to work out that these slopes are very different. And as a result, today as we speak and we talk about the envelope of child mortality worldwide, all children under 5 who die, you will see that there are a number of conditions out here in blue which represent newborn deaths. So overall, globally, 45% of all under 5 deaths are in the newborn period. And if I was to disaggregate that to say how many of these are in the first day or 2 of life, then almost half of all these newborn deaths are in the first 2 days of life. So hence, friends, is my point about the eye not seeing what the mind does not know. And it's extremely important moving forward that we look at some of these things, numbers and causes. But these are numbers and causes. Let's try and look at a few things which are the causes of the causes. And again, in the interest of time, I don't have time enough to go through every social determinant of health, but I'll focus on a few things which are relevant to newborn survival. So most of us, and certainly at this institute, you would recognize the whole issue of poverty through the many measures that we have of poverty. So we look at mortality and its distribution by either measurement of assets or income in one measure or the other, and we present mortality gradients through socioeconomic strata, quintiles typically, the richest versus the poorest. But there are also additional dimensions of looking at differentials that we look at globally through the context of geography. So we look at urban populations, people who live in big cities or rural populations, and by and large, we look at many differentials in terms of intervention coverage by this rather simplistic urban and rural divide. And that is where, in most cases, our disaggregation of the data stops by poverty and by place of residence. Now, in my own country, it's extremely difficult to convince policymakers that an asset quintile related measure is of policy relevance. So many times people turn around and say to me, I recognize that the fifth child, every fifth child does not get vaccinated. But the problem is that the fifth child is not standing next to the fourth. So tell me where these people are. And increasingly, these people are not simply picked on the basis of urban-rural divisions. The poorest of the poor in many places live in urban settings, in the urban slums. And they are not measured and picked up by our standard indicators. So one way of doing that is to look at differentials through the various measures that we have. So I also chair the countdown process, and I've done so for 15 years now, where we measure global progress in the 81 countries that have 98% of the global burden of maternal child mortality. And this is one of those things that we produce every couple of years. So you look at this, these are evidence-based interventions that impact health and survival. And this is the coverage. The band represents median levels of coverage, and the gray dots represent countries. So the simple take-home message from this is that countries vary tremendously in their coverage of essential interventions, and you can see that through the gradients. And across some interventions, the world does a very good job, immunizations in children by and large. And for others, such as care in and around childbirth, we do very poorly. Why? Because they require functional health systems. But this is not a very useful way of comparing because it looks at national aggregate data. So it presents a country as if it was a homogeneous whole. What is much more useful at times is to look at subnational disaggregation. And I'll give you an example from my own country. So these are multidimensional poverty index measurements by every district of Pakistan. And if you look at this, you can immediately try and sense that there is not just one Pakistan, there are probably 5 Pakistans by virtue of where people live and what they have. So there are parts of Pakistan where living standards and some subsections of the population would be comparable to Houston. And there are others where conditions are at par with what would be in Africa. And you can see this through a range of measures. So if you were to compare this map in terms of the distribution of multidimensional poverty and look at just one indicator, which is distribution of skilled birth attendance, then you will find that there's almost complete homology between the two. That the lowest coverage of an evidence-based intervention, skilled birth attendance, a skilled care provider at the time of birth, with where the indicators in terms of poverty and access are the poorest. So increasingly, we are moving away from aggregated to disaggregated information to get a better sense of who we need to target. So in health systems, what you can see quite clearly here, availability of health workforce and health workers is a critical measure. You just see in many parts of the country here where we don't have more than 20% coverage of skilled birth attendants. And why is that? And it's the same reason why in the US you have a positive program for encouraging foreign medical graduates to go to less populous populations, areas, and geographies, because very few people go there. So this is, again, the same map, and this is now a simple measure. So I estimated the numbers of pediatricians and obstetricians as just one measure of a skilled care provider by various districts of Pakistan. And you will find that the blue represent the major cities and the major urban populations, and roughly about 80% of all the qualified obstetricians and pediatricians are in a handful of urban settings. And in many rural population districts, you have less than 2 or 3 qualified people serving an entire population of a couple of million. Why am I telling you this? The reason is that we absolutely, for health services, have a big global challenge where the mortality currently clusters of skilled healthcare providers, not just physicians, nurses, midwives, ancillary health professionals, and their lack of concentration in some of the poorest populations is one of the most important attributes to persistently high burden of maternal and child mortality and morbidity. But there is one additional factor that I do want to underscore, and I did not quite understand this until fairly late. And that is the other dimensions of poverty that we cannot measure by just money or purchasing power or asset indices alone. When I read this statement by my Mother Teresa, I couldn't quite figure out what was she talking about, the poverty of being unwanted and unloved. And she was basically talking about the sense of hopelessness, the poverty of hope that many of these poor populations have. And let me try and illustrate this to you with one practical example. So my group does a lot of surveys and assessments, and this is one such survey that we did about 10 years ago, where we asked the standard things that we did at a household level across the country. And these represents, as I've said, the poorest and the richest, the typical way that we will do equity assessments. And we wanted to know how many of the pregnancies had tetanus immunization, how many were born in facilities, and you see the gradient that you typically see. The relative rich have access 80 to 90%, the poorest have about 30 to 40% access. No big deal, we knew this. But this time around, we added 2 additional questions to the DHS questionnaire. And they were very simple questions. Those questions pertain to simple things that we wanted to know. One of those was, had the husband and wife made a financial arrangement for childbirth? Just put some money aside, that if they needed to go in an emergency, they could do it. Or had a discussion amongst themselves about whether or not they would get delivered in a facility. Simple, simple question. And what do you see? What you see very clearly here is that in the vast majority, in 70% or thereabouts amongst the poorest of the poor, there was no discussion about whether or not money needs to be put aside, or that there was a question of delivering in a facility. These people simply did not imagine that their fate would be very different. This is the sense of hopelessness and the intractability of poverty that many people recognize amongst the poorest of the poor. And this has a huge bearing in delivery of services and in interventions that you need to put in place to address that issue. This is reflected in many of our rural populations. And what I'm telling you for Pakistan is absolutely true for the whole of South Asia. So be under no illusion that this is something specific to Pakistan. You see the same across populations in South Asia, whether it's India, Bangladesh, or Nepal. So you have a health system that functions because it has at its base some of these primary care facilities, secondary hospitals, and referral hospitals. On paper, things exist. But the quality of care and the sense that something can be done at this level of the health service is so poor that for reasons of this sense of, as I said, hopelessness and fatalism in this population, when people have a problem around maternal and newborn health, what do? They vote with their feet. They either try and seek care in the upper end of the health system, go to a city about 100 kilometers away at 2 o'clock in the morning, or they stay where they are. And as a result, in survey after survey after survey from South Asia, you see a pattern of distribution of deaths that indicates that about half of all deaths take place at home, in village settings. About a third make their way up the health system, and some die while seeking care. Now, if you remember nothing from today's talk, please remember this graphic because it will tell you why community health worker programs were developed principally to address these 2 basic barriers. Firstly, to address service delivery at this level, And second, to empower communities so that they could break through some of the sense of fatalism around maternal and newborn care. And that was one of the reasons why these programs were developed, to principally pull people out of the poverty trap. So in terms of what works, several strategies have been evaluated over the last 2 decades, principally to address this equity gap. One of those is community programs, community outreach services, where there have been health workers trained, either in the private sector or in the government sector, principally to do task shifting. So where there are no physicians, where there is no doctor, you either have nothing or you have somebody who can be trained to provide some basic primary care services. You can link community to facilities through innovative programs such as cash transfers and provide some incentives, transport systems. And the third strategy that people have looked at is creating demand, is just supporting communities in terms of breaking the sense of fatalism that I've talked about. Now, Pakistan was very fortunate that through the vision of one of its prime ministers, a wonderful woman, a female prime minister, who came back from a conference in Cairo in 1993 and said that I would like to do something for the poorest women in the rural parts of Pakistan. And she created the Lady Health Workers Program, which was a community health workers program where they took women, girls, with a certain level of education, trained them, placed them in that community, and gave them the wherewithal and support to provide primary preventive care, reproductive health services, and basic support in terms of measuring and monitoring events. The biggest opponents to that program were people like me, physicians, who thought that this would be quackery and that we would principally absolve the health system of its responsibility. Well, Benazir Bhutto fought that. She protected that program for 2 years in her own prime ministerial office. She gave that program shelter in the Prime Minister's Secretariat, and the rest is history. And that program became the backbone of a number of services in Pakistan. I'll talk largely about that program in a minute. But what has happened since then is a plethora of development of programs which have looked at both family and community packages of care, outreach services such as health workers operating out of primary care settings in rural populations, and facility-based care services. And the evidence indicates globally that if you're able to focus on these 2 levels, primary care, that you would be able to address maternal and newborn morbidity and mortality. This is a recent model, an estimation that was done as part of the Disease Control Priorities Project to say what could you gain from community interventions and primary care services. And you can see that in terms of reduction of both maternal deaths, newborn and child deaths, the maximum gains are at a community level if you're able to reach those who cannot be reached. And how many deaths can you avert? You can avert about 3/4 of all deaths, in theory, if you were able to implement these programs at scale. And we have looked at this evidence in 101 ways. So my group has led the global evidence synthesis around this, for looking at models of community and perinatal care, synthesized in several systematic reviews, also in reports for the WHO. And the bottom line is that these programs work. They can reduce newborn mortality by about a third, 29%, and they can reduce maternal morbidity by about a quarter. But the question really is, do all of them work equally? Many of these projects are small-scale NGO projects, research projects that people do and that are unable to sustain, and projects that do not necessarily have public sector workers behind them. So a big question, and in fact the challenge thrown by Farhan and his colleagues to me was, are all of these programs equal? And are there some that work better than others? So I will share my experience of working with some of these programs. And some years ago, before I started thinking of what to do with the Lady Government Workers Program, some of the evidence began to emerge from a simple set of interventions in South Asia in general, Nepal, Bangladesh, India, largely led by investigators from from London, from University College London and from Imperial. And these were women's groups. So these are not health worker-led programs. These are women's groups, which principally was an intervention of getting women together and getting them to do a diagnostic. It's a little bit like a self-help group that's put together to understand the genesis of problems, their own issues, and to talk a little bit about how they can be helped. To cut a long story short, there have been a number of these projects, 7 large cluster randomized trials done by this group. And the bottom line is that this group has been able to show that these interventions make a difference. If you can read forest plots, you will see that overall, almost all of these interventions have a mortality effect on reducing newborn deaths, about a 20% reduction in neonatal mortality. So there was some sense from this that empowering women through the self-help process could make a difference. The problem here is that this wasn't a government program, that when the investigators came, did the intervention and left, there was nothing left to sustain it. And in many instances, going back showed that they were not able to sustain it, that very few of these became indigenized as things that the community did themselves. So our interest in this was, could this work with public sector workers? So in the year 2000, I first floated an idea to the government of Pakistan for us to potentially work with the Lady Health Workers program, which at that time was not as large as it is now. 100,000 workers exist, and to allow us the potential of working with them in one model rural district where we could do everything through the program, but do the monitoring and evaluation alongside. And in order to do that, we needed to develop a model district which was replicable in terms of other provinces. It was not just in the boondocks and deserts of Pakistan, but it was in a reasonable agrarian population. And I'm going to show you where we set up our first community laboratory, where we've done a range of cluster randomized trials in rural Sindh. So this is the district of Matiari, which is an agrarian district. Used to be called, part of it used to be called Hala. It's a fairly reasonable program, and we were able to get private sector support to establish our field site here and a pretty state-of-the-art facility where we could do our monitoring and research from and work with the government program in the same area. So our first trial was to simply test the hypothesis that you could train these government health workers with community support to improve the care for mothers and newborns in this area. It's a large cluster randomized trial with close to around 1,400 villages, 250,000 population. It was done over a period of 4 years and was done through two core interventions. Creating community volunteer groups who principally provided support to health workers for them to operate in this area, provided them safe passage in many instances between villages, provided material support at times when needed in terms of transport funds. And the female health workers, the lady health workers, worked through the same principle that you saw in the community support groups, women's groups. They organized these sessions on a quarterly basis in the same community using virtually low-cost or no-cost processes like just assembling in somebody's yard and getting a group of women together to talk about their problems. I frankly thought that this would never work because it was such a low-cost approach and it was such a basic approach that to expect that it would have an impact on anything at scale was a little bit far-fetched. And we were already thinking of developing a more complex intervention at the time when this was being rolled out. Well, the results were astonishing. Firstly, we saw a huge change in practices. So antenatal care went up in intervention clusters. So the people going to both public and private sector for care. The use of clean birth kits, people went and bought clean birth kits. So these are not 100 people here and there. As I told you, it's a cluster randomized trial at a district level, so this is at scale. Cultural practices like throwing away the fore milk, which is considered stale milk in many of these rural populations, they changed. And something that people told us would never change. In our system, in our culture and religion, bathing a baby after birth, very soon after birth, is a very important part of purification before you could solemnize or baptize that baby according to Islamic tradition. It's been very, very difficult to change that. In this community, people at scale delayed bathing after 6 hours just to avoid the risk of hypothermia or the baby becoming cold. And something else happened. So there was an impact on newborn mortality, about 15 to 20% reduction that we saw. But then my team came back and said, we are beginning to see some data on stillbirth reduction. Stillbirths that I told you about require intervention in process of labor. And I asked them to go back to the drawing board because they did not believe the data. We had put no intervention in place to affect stillbirths. No new obstetricians, no hospital facility interventions. So how could stillbirths have gone down from a community-based intervention? And the penny dropped then that a large-scale change in behavior in terms of care seeking and accessing care within the facilities had happened. We went back 3 years after that original cluster randomized trial to look at the HMIS data on what had happened, and that has been the case. It's a little bit like once you learn how to swim, you don't generally unlearn it. Once a community starts accessing care in a facility, they typically don't go back to a traditional birth attendant. So that was the genesis of the HALA trial, which it made a lot of noise and splash at that time, also gave us confidence. Perhaps we were a little too overconfident in terms of what needed to be done, but it gave us that impetus of working with public sector workers. Not just us, many other people elsewhere. And that's why we have now a reasonably large number of public sector programs where community health workers have implemented things that we can compare. The next big challenge that came was, could this approach of using community workers or working with communities work in difficult populations? And by difficult populations, challenging populations. Not the stable thing in rural Pakistan, but perhaps where there is conflict. And one of the areas that we picked up was immunizations. So I've shown you maps of the country. This is a difficult map because it shows you children in Pakistan between 12 and 23 months of age who have never been immunized. And you can see that there are parts of the country, notably here in the tribal areas, where we either have no data or where the data indicate that close to around 20-25% of children have never been immunized. Now, if you were to overlay on this map a map of distribution of a disorder that the world is trying to eliminate, called poliomyelitis, you see an almost complete homology. You see polio cases in the very geographies where rates of immunization are lowest. In the borders areas between Sindh and Balochistan, in the city of Karachi, which has many no-go areas, and in this northern area. This was a big challenge at that time because the polio program was not only threatened by militancy, by the fact that these were the very areas which have high rates of conflict and poor access, but also that the communities themselves were very reluctant to participate in any interventions. So we undertook a large cluster randomized trial, one of the first in conflict situations, in these 3 difficult areas of Pakistan. We published this last year, in this border area, in the federal tribal area, which is the Taliban belt, and in the city of Karachi. And our intervention was very simple. The intervention was, in comparison to standard care, could you have a community mobilization strategy using existing community health workers and lady health workers in terms of getting community engagement intermittently? During the polio days, could you hold camps for maternal newborn child health and get people engaged? And could you add on to it an injectable polio vaccine, which at the time when I did this study was a big question mark? Could that be introduced in Pakistan without having a negative impact on the polio program? Well, the results were phenomenal. Firstly, it was a very difficult study to do. Why? Because you are working with extreme levels of insecurity. But it required community engagement, mobilizing whatever resources you had, community volunteers, leaders within the religious community, and importantly, the program that I'm talking about, the Lady Health Workers Program. They were the backbone of providing that level of community engagement and interaction. It required difficult geographies, topography, using four-wheel drives or four-leg drives when you needed to, and the turnout and community participation was unbelievable. My team did not have security clearance to keep these maternal child health camps during the polio immunization days open beyond a certain time. We were not allowed to stay in that area after dark for obvious reasons. And almost universally, we could not get out of that area before dark. Why? Because there were close to around 50, 60 people waiting, who had been waiting for hours. So the response was phenomenal. The participation was phenomenal, and I can only show you that through pictures. But the impact was huge. So firstly, we demonstrated that, if anything, that this approach of community engagement and using community health workers to engage with communities, even if intermittently, had a very positive impact on oral polio vaccine coverage. We were able to achieve, despite the fact that it was a new vaccine, close to around 80 to 90% coverage with the injectable polio vaccine at population scale. And importantly, this is a population where full immunization rates were very low, that we were able to get between 40 to 50% increase in immunization status at that population level. So the myth that this particular trial burst for me is that these health workers can only work in stable circumstances, that we were able to breach many a community barrier by using people from their own community, working with community members, and particularly women in that community who became the biggest stakeholders for this. The last challenge that we had, and again, the confidence of working with this program also means that you aspire to do more complex things. Could you train these health workers to do more complicated things? And there was some evidence from studies, smaller studies, that they could be trained to resuscitate newborn babies. They could be trained to treat babies with severe infections or give antibiotics. And that had been tested in both India and Bangladesh. So we undertook a large cluster randomized trial in the district north of my field site to work with this program to see if we could enhance this training, to train them in the early recognition of birth asphyxia and management, managing neonatal infections and low birth weight babies. And this was a complicated trial that required government participation over a period of time. And we used standardized training modules of low cost and low intensity training around newborn resuscitation. Many of you in the audience would recognize this program, which originated from the American Academy of Helping Babies Breathe. So, many things worked. We found that these community lady health workers were able to, interact with the community. Some of them attended births, but the overall coverage at best was only about 20%. And the reason is that there wasn't a financial incentive for them to attend births. I mean, to go at 1 o'clock in the morning to attend a birth in a neighboring village is something that requires a fair amount of motivation. We were amazed that out of the 1,000 lady health workers, 20% did manage to do that. They were very good at getting health education sessions, and you'll see over time about half of the population managed to, in the intervention area, attend health education sessions. But the stuff that we were interested in, getting them to use technology to manage things at home, was really a very small minority. And we also found that this additional intervention, although it did reduce newborn mortality overall to the same level as we had seen in our previous intervention, there wasn't an additional impact in terms of reducing it beyond that, and was not an additional impact on stillbirths. So the take-home message from this was that this was a failed intervention. And what it taught us was that there is a technological ceiling that these community health workers have in terms of what they can and cannot do, and we should not make an effort to convert them into physicians in lieu of what we have within the health system. The other lesson that we learned was that when you do community-based interventions, linking them to the health system and facilities for higher level of care is equally important, and therefore one should not look at these being an either-or solution. So let me now, at the end, answer the question that Farhan posed. And his question was, are these public sector community health workers as effective as small-scale community health worker programs who are principally trained and paid for by trials? And therefore, in our guidance to governments, could we say that public sector programs are where you should put your dollars and money in? To do this, we have looked at all the evidence that's available. So I've had to do this fresh for this particular talk. We've looked at all trials, all published data. This is updated up to this month. So these are looking at all randomized or cluster randomized trials and quasi-experimental control trials. We have looked at maternal and newborn outcomes. And there are actually 18 studies that we have included in this meta-analysis that include at least 6 to 7 trials which have used public sector workers. We have a nice balance of a 1-to-2 ratio of public sector workers versus community health worker programs. And they appear to be a reasonable mix in terms of the quality of the studies. So with some exception of outcome data, I think by and large, if you recognize this Cochrane quality of evidence graphic, these are reasonably strong evidence trials. So what did we find? Firstly, we don't have enough data on maternal mortality. So I think the universal agreement is for maternal mortality, you can do some stuff in community, but really have to do things at facility level to impact mortality. You can reduce morbidity somewhat, and the direction of effect is reasonable, but don't count on this for reducing maternal deaths. On newborn deaths, this is a busy graph, but I'll try and explain this to you. On the top are these public sector programs all over the world. So we have the India IMNCI trial, we have the trials done by my group, we have one study from Malawi, and we have a study from Ethiopia. So we have a reasonable distribution of Africa and Asia public sector programs that have looked at this. And if you look at the overall impact, it is all in the same direction. The randomized controlled trials outside the public sector appear to reduce newborn mortality by 25%. And those within the public sector program appear to do so by about 14%. Am I out of time?
Almost. Just in case.
Perinatal mortality, which is a combination of newborn mortality and stillbirths, goes down by comparable amounts. So both work. And there is no reason to assume that public sector programs will not reduce perinatal mortality. And you see that why? Because they do reduce stillbirths through a process which we believe very strongly now is through improved care seeking in the system. So there is clear evidence that these public sector programs in the community do improve community care seeking. What is the evidence that it does so? So we've got 2 measures for you to see from this analysis. Firstly, institutional deliveries, by and large, appear to go up in public sector programs where this has been measured. This is not significant, but it's in the direction that you would expect. And if you look at measures such as initiation of breastfeeding, household level domiciliary practices, huge impact of these programs in terms of early initiation of breastfeeding within an hour of birth. So I think the salutary analysis of public sector programs is that they are just as effective as small-scale research projects done with community health workers. And I think that's a very important policy message for governments who are reluctant to invest in these programs. The one feature of these public sector programs is none of these are voluntary. Whether you're looking at programs in Pakistan or India, they are remunerated programs. So there is nothing like health volunteerism in terms of health workers functioning at that level. Our own analysis for WHO about 8-9 years ago said the same thing. If you want health workers to function with any length of time and ownership, then they really need to have that level of engagement and support by the government. So let me conclude by just making 4 observations. Firstly, reducing inequities in global maternal and child health is a moral imperative. It's a global moral imperative, and it will not be achieved with just secular trends. This will require targeting because, as you saw, just depending upon the momentum of change means that many people will be left behind and that averages will mask behind them tremendous inequities in various geographies. These health worker programs, particularly public sector community health worker programs, can play a critical role in reaching marginalized communities, not just in rural populations, but as you saw, in very difficult circumstances. I now lead a consortium looking at the entire evidence of what works in conflict settings, and particularly in conflict and settings in insecure areas, there is a real role that these community programs can play in reaching people who are otherwise not being reached. Thirdly, public sector programs like these have a tremendous potential of impacting population-level behavior change and care seeking. So this should not be just viewed as service delivery programs. They have a potential, as we see in the global evidence around maternal and newborn care, of educating, supporting strategies for women, and where a lot of focus needs to go now is empowerment, is strengthening, particularly young women and women in marginalized populations in terms of standing on their feet and standing with this communal unity of holding each other's hands, something that was recognized from the women's support groups only. So they have a huge potential of addressing one of the biggest gender inequities that we have globally. Lastly, to make a difference at a global level, these will require investment. This will require nurturing such programs. As I said, changing our mindsets from these being volunteerisms and sporadic programs to a much more focused investment by governments in reaching the poorest of the poor. And this change of mindsets is extremely important. And let me finish. I've given you a number of quotations from Nobel laureates from my part of the world. Let me finish with another favorite quotation of mine. It's from someone who did more for women's empowerment in South Asia than many others. And what Muhammad Yunus said many years ago, that his greatest challenge was to change the mindset of people. Mindsets play strange tricks on us. We see things the way our minds have instructed our eyes to see. Thank you very much for your attention. I'll be happy to answer questions.
Any questions? We can have a Q&A session.
Please.
Hi. Thank you so much for this wonderful presentation. And so I was curious whether you are familiar with the data in the United States about maternal mortality, and especially in Texas, and what are your thoughts about that in the context that you described to us?
So that's a great question. I am familiar with the data from Canada and the distribution of morbidity and mortality, premature mortality, not just in women, but also in young people amongst the northern Inuits. And we believe from that information available that what I've been talking to you about community programs and principally embedding workers and volunteers from the community within those services have tremendous potential of reducing those gaps that cannot be addressed by other means. So I live in Toronto, and the Ontario government, on average, spends about $100,000 a month in airlifting young people at risk of suicide from the north to Toronto, providing them some care, sending them back, and then bringing them back again after 3 months when they're at risk. And it makes no sense to do that if you are able to put community programs in place. The challenge there is that there hasn't been that kind of a thought process of something that can be developed prospectively over a period of time. So to answer your question, I am quite convinced that there is the potential for the same kind of community outreach program in North America, US included. I don't know about Texas, but I certainly know about Ohio, that in Cincinnati, one of the biggest programs that people are looking at is these community outreach workers who are reaching out to young mothers. So, but there isn't the systematic collation of evidence, and there aren't the randomized controlled trials yet that we would like to see. But this is where reverse innovation may help. What I've told you today about innovations in the South, in poor, low, middle income settings, have possibilities for developed health systems in more than one area. And they have also tremendous potential of reducing transactional costs of care, doing things much more cost effectively. Please.
I'm curious about the workers who become the community health workers. Is this an attractive job? Is it something that these people want to continue doing? Is it considered prestigious, or is it looked down on because it's a government job?
So I should share with you all the literature that one of my students, Subia Mumtaz, has written on social empowerment of women. So it's a mixed bag. And the lady health workers who became lady health workers in Benazir Bhutto's time in the 90s are very different from the workers who are coming into the pipeline now. They are, by and large, a mixed bag of young girls who are now in many instances mature girls, mature women, where they come into this with some degree of a spirit of volunteerism. It's not the easiest of jobs. In a patriarchal society, to be a female worker who goes from house to house and does a few things is not necessarily the most attractive of positions. They do put themselves at risk, particularly when they do the polio work program. In Pakistan, when the Taliban and the obscurantists started killing health workers, the biggest group targeted was the lady health workers. And they were deliberately targeted to put the fear in the community at large. But they are also now, once they have been in place, one of the most empowered women. So they have a career pathway. They go from being lady health workers to lady health worker supervisors. They typically would not be able to rise beyond that unless they had a higher educational degree. But we did a very interesting survey where we asked traditional birth attendants as to how did they see their daughters in the future. And not one traditional birth attendant wanted her daughter to be a traditional birth attendant. And they aspired to have them come into a cadre like the lady health workers. We've recently looked at this by asking lady health workers as to how they see their daughters. And not one lady health worker wants their daughter to be a lady health worker. They want them to be a qualified nurse or a physician or to have a profession where they can go higher. So I hope that indirectly answers your question. Yeah. But it is a step-by-step process on social development and empowerment.
Yes.
Thank you for a great presentation. A two-part question. If you look at a lot of the countries in the Indian subcontinent, the percentage of expenditure, government expenditure on public health is abysmally low. And obviously a lot of these community health worker programs are still top down. Have you in your surveys ever found attempts to try and mobilize the public voices to try and get more attention? Because otherwise, the political will normally, reacts to a demand from, bottom-up demand. But there is a degree of fatality built into the psyche of the person at the bottom of the pyramid. Has that been changed in certain markets? Have you noticed that?
It's changing, and I'm sorry, I don't know where you're from originally, but I can give you an example from the JSY program in India.
Well, UK and India, yeah. So yeah.
So the JSY program, to those who don't know, was a cash incentive program principally to encourage families to deliver in facilities. And it also had a link to the ASHA workers, which are community health workers in India, in terms of facilitating that linkage. And what it did dramatically was to increase the proportion of births in facilities within a very short period of time, to around 80–90% in some of the poorer states. Now, the question was, what do people get when they go to those facilities? Because the quality of care was so low. And a lot of people in the early days of the JSY program looked at all of it and evaluated and said it's a total failure. They're going to those facilities, but mortality hasn't begun to come down. But it takes a little bit of time. So one of the biggest things that's happened in India, this is why I raised this example, is that pressure from the community. Once you go to a facility and you don't find a drug and you don't find a physician, the indirect pressure on creating that demand for improved services is one of the biggest reasons why in India there is now such tremendous investment on strengthening district infrastructure and health system infrastructure. So that's the same in the geographies that I'm talking about. There is a slow, steady progress where these communities, when they become empowered, they also raise their voice. When they see that despite all that you can do at a household level, you don't see the same quality of care improving in facilities, then those demands for their facilities also go up. So it takes a bit of time. The bottom line is, yes, the subcontinent, India, Pakistan, Bangladesh, all really need to spend much more on per capita health than they are currently doing. And it probably needs to come out of the defense expenditure that none of us can afford. Please.
So my question is, it's not technically neonatal, more under 5 mortality. So do you, that comes from under 5 mortality, but so do you see this similar program working in urban slum setting? And the reason I ask is, during my brief stint in one of the non-profits that had community health workers in Dharavi, this was an NGO training community health workers. They were looking at stunting. So they were going and counseling parents and taking the kids to the hospitals. But when they tried to hand it over to the government employees, the ICDS, the public distribution day and things like that, there was a lot of pushback, and there was a lot of politics behind it as well. So that you think it will work?
There's no public health without politics. And stunting is a difficult one.
Right.
And the ICDS program is an even more difficult one. So the answer to your question is, could things work in urban slums? And the answer is absolutely yes. I don't know if there's anybody here from Bangladesh, but there is a big program that BRAC has been running in urban slums. And although it's not been evaluated very effectively, from the process data, it looks like they've been able to access. There's one in Mumbai that Tony Costello's group been looking at for a while. So you need to have different interventions because urban slums, by default, don't have the same access issues. I mean, there are lots of other structural issues in urban slums, but they require innovations of that kind, and there's no reason why they cannot happen. There's just not enough randomized controlled trials in that area. One last question. I see a hand there.
In your trial on polio vaccines, I was curious why adding the injectable increased vaccination rates. People are usually scared about that.
That was counterintuitive. You mean say increase the oral polio vaccine rate? Oh, I have an answer for that. The counterintuitive thing was there was a lot of concern in the program, both in Geneva and in Pakistan at the time when we started this, that we should keep the injectable polio vaccine under wraps because of the community pushback against oral polio vaccine and a lot of the propaganda that the oral polio vaccine contained harmful substances, maybe family planning substances, which is what had come out of the obscurantists from Nigeria and elsewhere. So the fear in the program was that you put an alternative vaccine in place, people will stop taking the oral polio vaccine. And actually, yes, there are about 10 to 15% refusals of oral polio vaccine at home. So these SIAs or these polio immunizations are door to door. People go and get vaccines at home. Now, what happened in these communities was that people refused the vaccine at home. But when they came to the camp, they received it plus the injectable vaccine. So they were willing to receive the oral polio vaccine in the secure environment of a maternal child health camp, as opposed to their neighborhoods when everybody in the neighborhood was watching them. Mm-hmm. So the increase that you see, it's a small but significant increase in that arm was due to the combination of IPV and OPV in that circumstance. It's a great natural experiment of what are the barriers to receiving oral polio vaccine in such setting.
So, thank you, Dr. Bhutta. Thank you so much for that.